Cardiac Emergencies. Assessment and Treatment by Aaron Oliver and Kayla Green. Certified athletic trainers are most likely the first to respond when cardiac emergencies occur in the young athletic population. Cardiac emergencies are emergencies involving distress to the heart. There are many different kinds of cardiac emergencies, but we'll focus on what athletic trainers are likely to see in emergency situations.
So step 1 is going to be recognizing that there is an emergency. After witnessing the athlete collapse, check their level of responsiveness using the APTHU scale. It should be assumed that all collapsed and unresponsive athletes are experiencing a case of sudden cardiac arrest, or SCA. SCA affects over 400,000 people each year and is the leading cause of death in young athletes. Thus, it is the cardiac emergency that we are most likely to see as athletic trainers. The research shows that in young athletes it can be caused by genetic or functional structural heart abnormalities, electrical cardiac disorders, illnesses such as myocarditis, and the trauma-induced commotio cordis. Commotio cordis, also referred to as concussion of the heart, should be identified as the cause of SCA in young athletes who collapse after taking a hard blow to the chest during the repolarization phase. The survival rate for this traumatic event is a mere 15%. Nearly half of SCA cases in young adults and young athletes is caused by hypertrophic cardiomyopathy, which frequently doesn't present any signs until SCA occurs.
Signs and symptoms. Seizure-like activity is a common symptom of SCA. It may be seen in about half of young athletes with SCA. Therefore, this symptom should make you assume SCA until it can be ruled out. Agonal respirations and intermittent gasp are not signs of normal breathing patterns and are another way to recognize SCA early on, usually within the first 5 minutes. Tachycardia and fibrillation will also occur, giving them a quick and irregular pulse and subsequently leading to a drop in blood pressure. If SCA is left untreated, death can occur within 10 minutes due to the lack of oxygen. Severe brain damage can occur in just 5 minutes. This is why quick intervention is so important in these scenarios.
So now step 2 is going to be calling for help. It is important to call for emergency medical services as soon as possible. If somebody's nearby, tell them to go call 911. And then step 3 is going to be checking for breathing and performing CPR. We want to perform the head tilt chin lift maneuver and look, listen, and feel for breathing. If breathing is not detected, proceed by giving 2 rescue breaths. As an AT, quickly check the pulse. If they don't have a pulse, then CPR is the next step. You should begin by applying 100 chest compressions each minute at a depth of about 2 inches. Full chest recoil should occur between compressions. We want to alternate between cycles of 30 chest compressions and 2 breaths. When giving breaths, pinch the nose and make a complete seal around the mouth. Blow in for about 1 second while looking to make sure that the chest rises. CPR should continue to be administered to the unresponsive athlete right up to the moment that an electrical shock is delivered by an AED. After the shock is delivered, CPR should continue, starting with chest compressions. The AED will walk you through this process and tell you when to allow for rhythm analysis every 2 minutes or 5 cycles. You should only stop performing CPR during rhythm analysis, shock administration, if you are relieved by EMS, or if the patient becomes responsive.
This leads us to step 4, defibrillation ASAP. Ideally, AED should be on the sideline and close enough to be easily obtained within 3 minutes. Research shows that the time between the onset of fibrillation and the application of defibrillation is the most crucial factor to survival in these emergencies. The chance of survival decreases by about 50% for every 3 minutes that the administration of defibrillation is delayed. According to the NATA, the survival rate drops by 10% for each minute that defibrillation is delayed. On the other hand, survival rates are around 90% for those situations in which defibrillation was applied immediately. Therefore, someone needs to immediately retrieve the AED. It is very simple to use. Turn on the machine, apply the 2 electrodes to the chest, press a button so it can detect the heart rhythm, and if need be, press another button to deliver a shock. Make sure to stay clear so that nobody is touching the athlete while the heart rhythm is being analyzed and the shock is being administered. The AED will walk you through the process of administering CPR and additional shocks if needed after the initial shock, as was mentioned earlier. If no shock is suggested, you should still continue with CPR until the athlete becomes responsive or another cause is identified. If there are numerous people around, then steps 2, 3, and 4 should occur simultaneously. If you are the sole responder, then calling 911 should be done first. Retrieval and use of an AED should come second if possible. Otherwise, you need to perform CPR until either more help arrives or the athlete becomes responsive again.
So it's recommended that SCA patients are transported to a hospital with advanced life support. Also, a hospital with therapeutic cooling is ideal for patients who struggle to regain cognitive function. Induced hypothermia has been shown to increase the chance of survival for these patients. Athletic trainers most commonly work with healthy athletes, but they need to be prepared to work with other members of the population, thank you for that, Car, including coaches, referees, and bystanders.
Myocardial infarction, also known as a heart attack, is the cardiac emergency that the AT is likely to deal with outside of their athletic population. Symptoms include chest pain, profuse sweating, shortness of breath, dizziness, nausea, and referred pain, which usually occurs in the left arm. Go ahead and do a thorough assessment, including vital signs. Encourage the patient to get into a comfortable position, whether they sit or lie down in a reclined position. Also loosen any tight clothing causing excess discomfort. EMS should be called right away. Our book says to administer oxygen to these patients, but the research we read says not to because it has not been shown to help. Regardless, vital signs should be continuously monitored, and you should always be prepared to provide CPR and use an AED if the patient goes into cardiac arrest. Another condition that we might see is called angina pectoris. It presents similarly to myocardial infarction in terms of its signs and symptoms. Usually, athletes will have already been previously diagnosed with this and will usually have a prescription for nitroglycerin. Athletic trainers should help administer the nitroglycerin to these athletes depending on their state laws. If the nitroglycerin does not help symptoms improve, then they should be treated the same way as a myocardial infarction patient. Any athlete who experiences chest pain should have medical clearance from a doctor before returning to play.
So now we'll look at some more studies. So studies by the American Heart Association show that healthcare professionals frequently misdiagnose pulselessness. Pulselessness is only accurately identified by health professionals about 50% of the time. Therefore, the latest recommendation is for the pulse to be assessed for no more than 10 seconds by healthcare professionals, and non-healthcare professionals should not bother to check for a pulse at all. Recommendations for CPR protocol have gone through a few changes since it was first introduced in 1960. For a while, it had been thought that the best process included chest compressions and rescue breaths. But lately, some have been enforcing the concept of just doing chest compressions as to avoid the interruption caused by rescue breathing. Most recently, the University of Arizona School of Medicine thinks that the hands should not remain on the chest during compressions, but instead thinks that the hands should be lifted slightly off of the chest during compressions. They think that this creates a vacuum effect in the lungs, thus making rescue breathing unnecessary. Another CPR guideline has experienced a recent change. We have been using the acronym ABC to describe the order for checking airway, breathing, and circulation, or chest compressions. But now the rearranged acronym CAB or CAB is being taught so that chest compressions can be initiated sooner.
The key thing to remember with cardiac emergencies is the word early. We want early recognition of the emergency, early activation of EMS, early CPR administration, and early AED application, and early access to ALS to increase our athletes' chance of survival and to avoid any unnecessary detriments to their health.